Now, going further into hypoxemic respiratory failure, yeah, there could be different reasons why hypoxia can happen. The most common is when the acute cardiogenic pulmonary edemas, ARDS, post-extubation respiratory failure, post-surgical respiratory failure, respiratory failure in immunocompromised patients, or in those patients with chest trauma, or palliative, that is, do not resuscitate or do not intubate patients. As I told you, ARDS again, we will definitely see how and which categories of patients we can consider to use it. And acute cardiogenic pulmonary edema is one good area where we can still use it because we did see that it helps to reduce the afterload. And as a result of this study was also done, and it was proven that it helps to reduce the work of breathing, reduces the afterload, and therefore, because of the positive pressure, it also opens up the alveolus. It also helps to drive the fluid out of the alveolus. It keeps the alveolus open and helps to recruit certain amount of alveoli which are there. And in acute care settings, it also helps to reduce the respiratory rate. Overall, it is much more beneficial to use non-invasive. Mind you, into those patients where there was to extreme shock, if there is a hemodynamic instability, you're supposed to use it very judiciously. Possibly, you may have to initially use invasive mechanical ventilation if the patient is in cross cardiogenic shock. And non-invasive ventilation, again, for cardiogenic, it is the second most relevant kind of evidence. Almost about 5 million patients in USA and 15 million in Europe suffer from heart failure. And the Cochrane review, it was that it was one of the most convincing meta-analysis as far as the use in patients of acute cardiogenic pulmonary edema. Now, whether BiPAP or CPAP, both were given. Non-invasive ventilator supports CPAP or BiPAP for cardiogenic pulmonary edemas, and this was a Cochrane review. It was mainly done to determine the effectiveness and the safety of non-invasive positive pressure ventilation into those patients with cardiogenic pulmonary edema, and almost about 3,000 patients were included. And over a period of time, this study was seen as far as intratracheal intubation requirements, the hospital mortality, as well as the outcome. And better outcomes were seen into the group where non-invasive mechanical ventilations were used and also reduces the incidences of endotracheal intubation. In ARDS, yes, there's been conflicting kind of etiologies. It is multifactorial. It is selection has to be done very judiciously and properly. We need to select the right patient into this, and only the mild kind of, even as we already consider the Berlin definition of a chart which is being given for the treatment, only into the mild forms where the PF ratios are not severely affected or between 200 to 300, that is the category range. You may consider to use it depending upon the hemodynamic status, but mind you, in patients of ARDS, it has to be used very judiciously. It has to be used with a real pinch of salt, and it requires high level of monitoring, and you should be on the high alert for converting it from non-invasive to invasive mechanical ventilation. Now, high flow oxygen through nasal cannula, again, I told you, yes, it is very promising. This is almost gives a continuous liter, about 40 to 60 liters of high flow of nasal oxygen, which is being given, and it generates a peak of about 6 to 8 centimeters of water. And this is almost vis-a-vis over a period of time, may think as one of the replacements for non-invasive mechanical ventilation. So the conclusion into this study was non-hypercapnic acute hypoxemic respiratory failure treatment with high flow oxygen, standard oxygen therapy, or non-invasive ventilation. It did not result in a very significant amount of intubation rate. So even if you give amount of high flow oxygen, or even if you give non-invasive ventilation, the chances that there was a reduction in the patient did not require intubation. That was the most important thing. And the effect of non-invasive ventilation via helmet and a face mask on the rate of endotracheal intubation in patients with acute random respiratory failure. In the patients where, if you really can now see here, the probability here is in the helmet mask as well as the facial mask. The overall, if you really see, the facial masks were much more better, and even in certain subset of patients, the helmet mask were again beneficial. But again, as I told you, the interface, you have to select the interface depending, every patient may vary, and you have to select the interface very properly so that which patients may be comfortable into which patients. And into this study, they did see the inclusion criteria were adult patients. They had ARDS according to the Berlin definition. And those patients who had improper GCS, poor cuff reflex, those who are in tracheostomy, upper airway obstructions, and after 8 hours of non-invasive ventilation via face mask, they did a randomization into a face mask or via helmet. And that also did the NIV titration protocol was given. The NIV was titrated from 2 centimeters by out increments so as to deliver the best amount of pressures of IPAP and EPAP as well as the pressure cycling was also done. And at the baseline level, the Apache scores, which were seen into the group where face masks were almost comparable, they also did see the pressures were also quite comparable into this group. And over a period of time, the primary outcomes of endotracheal intubations or the mass deflations which were mainly seen. And, and if you find that there was not much amount of difference, and in the group where in the non-invasive facial intubation, the endotracheal intubation and the helmet intubation, the absolute incidences was statistically significant, and the mass deflation rate mainly was quite less, and the skin ulcerations were also very minimal when seen in the group where a facial mask was also used. Now, in immunocompromised patients, endotracheal intubation into this subset is associated with substantial mortality, and NIV is helpful to decrease the intubation, but the data are again conflicting into it. Basically, those patients with solid organ transplants, hematological malignancies, immunosuppressed patients do not, or into the immunosuppressed patients, HIV with pneumonia, these are the patients where you want to avoid exposure, so you prefer to use non-invasive mechanical ventilation. So the efficacy of non-invasive versus oxygen therapy into immunocompromised patients, this paper was published in JAMA 2015, where oxygen alone was given, and in another group of patients, the yellow line, where non-invasive mechanical ventilation was given. And we did see that in the group where non-invasive mechanical ventilation was given, the need for invasive mechanical ventilation was less. Also, they also found that the length of hospital stay was comparatively less into the group, and over a period of time, the chances over that non-invasive mechanical ventilation did was beneficial into group rather than invasive mechanical ventilation. In the perioperative or the post-operative patients, there were 2 trials. This was again a Cochrane database. It compared oxygen therapy, CPAP as well as BiPAP to reduce the chances of endotracheal intubation, and there were not much amount of differences which were found for hospital mortality as well as the hospital length of stay, and no effect was seen onto the anastomotically or in pneumonia-related complications and in patients of sepsis or in patients of those who are infected. So those patients who require tracheal intubation, the effect of non-invasive ventilation on tracheal reintubation amongst the patients with hypoxemic respiratory failure following abdominal surgery. This is quite about 2016. This was published into JAMA, and they studied approximately 535 patients here, and they were randomized into 150 patients were to receive standard oxygen therapy, 150 patients again received non-invasive mechanical ventilation, and these what were analysis which mainly came out was pneumonia to the standard oxygen therapy was pneumonia at the age of day was 32, day 7 was 32 in non-invasive group. There were only 15 patients. The pneumonia at the end of day 30, there were less incidences of complications into the non-invasive group, and a 30-day mortality was also less into the group of use where non-invasive mechanical ventilation was used even into the post-operative subset of patients. Now into chest traumas, those patients who have had chest traumas or those patients of road traffic accidents. Here 10 studies were done, and we did a systematic analysis or a meta-analysis, and 10 studies were taken and they met the inclusion criteria, and these were included as a meta-analysis, and the relative risk of these patients treated with non-invasive compared with standard oxygen therapy and invasive mechanical ventilation. And the many results suggest that non-invasive, it could be useful in the management of acute respiratory failure because of chest trauma. And it helps to again reduce the chances of intubation, reduces the length of hospital stay, also the mortality. Again, for acute, this is a paper which was published in Heart and Lung, non-invasive ventilation for acute lung injury, and the meta-analysis of these randomized controlled trial. It again suggested that the meta-analysis with 17 RCTs, they showed NIV, it significantly reduced the intubation rate, the length of hospital stay, reduced the mortality, and the length of hospital stay ICU mortality was not much different, but overall that was better, and the effectivity was again much more better in the group where these patients were used. Now, weaning is again an indication where sometimes we find that these patients have hypercapnic failure, we intubate them, next day they are quite alert, and we don't want to again extend ventilation. We can consider to early extubate them and consider them to be put on to non-invasive ventilation. So, to wean the patients off from invasive to from invasive to non-invasive, NIV is again an excellent tool, and this again has been studied by a Cochrane review database which was available. And in chronic respiratory failure, post-acute hypercapnic respiratory failure, or severe stable COPD with chest wall disorders, neuromuscular disease, or those patients with obesity, hypoventilation, or obstructive sleep apnea, where we can consider to use non-invasive mechanical ventilation. Now, domiciliary or the home care, we see that definitely it is beneficial, and the expected benefit of domiciliary home non-invasive is better because we reduce the chances of admissions or recurrent admissions to the hospital. These patients have got a better quality of life. The breathlessness also goes down. The sleep pattern and the sleep is better. They can go and travel all over the world with non-invasive. They can also exercise with non-invasive. And more importantly, their confidence goes up, and thus the survival is also going to go up. And the indications when to start domiciliary treatment is if you have had 3 episodes of more than 3 hypoxemic respiratory failure, those patients who are difficult to wean, those COPDs where they have got a CO2 of persistent about 40, about 55, and there is also increase in the PaCO2 under oxygenation, or the procedure performed is by nocturnal saturation. We do a sleep study into these patients. The quality of life assessment is also done, and that's how we try to come to the conclusion as which patients should be selected for. Now, which mode should be considered into this? More importantly, it is the pressure support mode, domiciliary treatment and COPD, the international indications. The interface, we see that which mode, the pressure support mode or the CPAP mode was again considered into this group. Majority of the patient, the pressure support was the main mode which was used, and the interface, either the nasal or the oral nasal mask, they were the main interfaces which were used for domiciliary treatment. And nocturnal non-invasive positive pressure ventilation for stable COPD. This was way back again a Cochrane review which came up, and this suggested that it is much more beneficial. And the conclusion was nocturnal NIVP at home for at least 3 months of hypercapnic patients with stable COPD had no consistent clinical or statistically significant effect on gas exchange, exercise tolerance, lung functions, respiratory muscle strength, or the sleep efficacy. Now, those patients where the mechanics is a problem, where you have got kyphosis, kyphoscoliosis, and these are the patients where the vital capacity of the lungs is also reduced, and these patients repeatedly they have developed a cor pulmonale, the life expectancy also goes up, and over a period of time, these patients require repeated hospitalizations. These are again the subset of patients where definitely non-invasive mechanical ventilation, it supports the ventilation. Up to 50% of these patients again die if proper respiratory support is not given. And these recommendations that these patients should undergo testing if their functional capacity is less than 50%, long-term non-invasive support should be offered on the domiciliary treatment. And these patients who are again developed with hypoxemia but without hypercapnia, they also can be managed cautiously with oxygen therapy alone while monitoring for the hypercapnia. And you should definitely see that oxygen therapy has to be added along with non-invasive mechanical ventilation if required so. And it helps to reduce the work of breathing. And we can see that the quality of life is also better, and the morbidity, mortality also goes down. Now, this has again been backed up by papers by efficacy of non-invasive targeted ventilation in patients with respiratory failure in patients of kyphoscoliosis. And the results, this was again a paper which came up, and we included these patients, and the author found significant improvement in the diurnal of the PO2 as well as the PaCO2 on the fifth day of non-invasive mechanical ventilation. And the non-invasive mechanical ventilation was well tolerated, and no patient discontinued the treatment during these observational period, and that's a very important thing. Now, in amyotrophic lateral sclerosis, again, there could be orthopnea, there could be hypercapnia of daytime, and we need to see that the functional vital capacity is again reduced by less than 50% of the predicted, and this is the time we see the sniff nasal pressure of less than 50, and this is the recommendation to selected of these patients, and we must offer them nocturnal NIV to these patients with diurnal hypercapnia, and when bilevel ventilation is used, the backup respiratory rates are usually recommended during sleep, and individualize the decision about the transition from nocturnal NIV to daytime ventilation by carefully evaluating the patient's functions. And we need to monitor the lung volume recruitment maneuver should be introduced with declining amount of vital capacities. And in more importantly, you should summarize it in a proper way that the selection has to be proper. There are broadening indications, but in order to avoid failure, selection of the patient, the right patient, is very important. Modality of the choice is mainly to acute COPDs or acute cardiogenic pulmonary edemas. We have to select the right interface for the right patients. Know the limitations of use of non-invasive mechanical ventilation. You should be on a high alert of converting non-invasive to invasive mechanical ventilation, and it can be applied at the various levels. I told you to the wards as well as ICUs, the SDUs, homes, and even into ambulances by well-trained persons.